Hi everyone, welcome back. Today we're starting a deep dive into chronic heart failure management. If you find this clinical content helpful, don't forget to like and subscribe for more medical education. Heart failure is a dysfunction of the myocardium that leads to neurohumoral and metabolic changes, resulting in the inability of the heart to provide a cardiac output adequate for the body's needs. It may occur as a consequence of structural or functional conditions such as hypertension, ischemic heart disease, or valvular disorders. Heart failure can be classified as right-sided, left-sided, or global, or according to the NYHA classification. It can also be classified according to the ejection fraction as reduced, mildly reduced, and preserved, HFrEF, HFmrEF, and HFpEF. Clinically, patients may present with dyspnea and fatigue with reduced exercise tolerance, palpitations, and dizziness, cough and tachypnea, weight gain with peripheral edema, jugular venous distension, and polyuria. As a standard diagnostic test, NT-proBNP is measured. NT-proBNP is secreted and released by cardiomyocytes in response to myocardial wall stretch. Its role is to reduce cardiac workload through vasodilation, lipolysis, diuresis, inhibition of the renin-angiotensin system, and reduction of myocardial fibrosis. Although the pathological cutoff value is generally considered 300 pmol, levels may be lower in obesity and higher in renal insufficiency. The obese myocardium secretes smaller amounts, and once released, these peptides are captured by NPRC receptors, which are abundant in adipose tissue. Through these mechanisms, circulating serum levels may be relatively reduced, as well as their ability to provide cardioprotection. Once secreted, NT-proBNP is eliminated renally, which explains why renal impairment can increase circulating levels. In addition to NT-proBNP, BNP can also be measured, although BNP is chemically stable only for a few hours after blood sampling. Additional laboratory tests include complete blood count, electrolytes, GFR, creatinine and urea, glucose and HbA1c, transaminases, total protein and serum albumin, C-reactive protein, TSH, lipid profile, and urinalysis. Treatment includes non-pharmacological, pharmacological, and invasive approaches. The main non-pharmacological measures include physical activity and exercise, as well as smoking cessation and alcohol avoidance. Although salt restriction, weight loss, and fluid restriction are commonly recommended measures, they may be associated with renal insufficiency, hyponatremia, confusion, delirium, and frequent hospitalizations, and therefore should not be imposed aggressively on patients. Several medications have proven effective in the treatment of heart failure. First, renin-angiotensin system inhibitors. ACE inhibitors are usually the first-line option, with angiotensin II receptor blockers, or ARBs, used as alternatives when ACE inhibitors are not tolerated. Then there is the angiotensin receptor neprilysin inhibitor, or IRNI, sacubitril valsartan. Under ARNI therapy, BNP degradation is blocked and values may appear falsely elevated, an effect not seen with NT-proBNP. Beta blockers like bisoprolol and carvedilol are essential, as are mineralocorticoid receptor antagonists, or MRAs. Spironolactone is frequently associated with gynecomastia, an effect not observed with eplerenone. This class has a mild diuretic effect but may induce hyperkalemia. Sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors, like dapagliflozin and empagliflozin, have proven effective. These drugs have significant nephroprotective and diuretic effects. Ivabradine is an IF channel blocker that reduces heart rate without lowering blood pressure. It is indicated in ejection fractions under 35% and sinus rhythm above 75 per minute, but is contraindicated in atrial fibrillation. Loop diuretics, such as furosemide or toracemide, are added in cases of volume overload as symptomatic therapy, but without a significant impact on mortality. Digitalis glycosides like digoxin are currently considered largely obsolete and reserved as a backup therapy. Vericiguat, a soluble guanylate cyclase stimulator with vasodilatory effects, may be used if the patient continues to experience decompensations requiring intravenous therapy. The greatest benefit is observed in patients under 75, but it has a relatively high rate of adverse effects such as anemia, hypotension, and syncope. The therapeutic algorithm follows a structured path, beginning with an ACE inhibitor, ARB, or beta blocker, preferably an ACE inhibitor. Then, the combination of ACE-ARB and beta blocker. The third step adds an MRA or SGLT2 inhibitor, followed by the quadruple therapy of all four classes. ARNI may replace ACE-ARB if EF is under 35% and the patient remains symptomatic. The following medications may have adverse effects or contraindications in heart failure and should be used with caution. Calcium channel blockers. Amlodipine is the only accepted exception as a reserve antihypertensive. Moxonidine, minoxidil, dihydrolazine, NSAIDs, COX-2 inhibitors, metformin, and DPP-4 inhibitors. Caution is especially needed with saxagliptin. While the mechanism remains unclear, it is associated with potential worsening of heart failure. Recommended vaccinations for patients include influenza, pneumococcal, and COVID-19. Finally, invasive treatment offers three primary therapeutic options. The first is cardiac resynchronization therapy, or CRT. The second option is the implantation of an ICD. And the third option is the use of ventricular assist devices, or VADs. That concludes our series on chronic heart failure management. I hope you found this technical review valuable for your clinical practice. Thank you for watching, and don't forget to like and subscribe for more medical education.